Welcome to Session 3, Advances in Cancer Immunology for Improving Clinical Outcomes. This session will be moderated by Sangeeta Goswami, MD, PhD, Assistant Member of the James P. Allison Institute, and Associate Professor of Genitourinary Medical Oncology and Immunology at MD Anderson Cancer Center. Dr. Goswami is a physician scientist whose work focuses on dissecting and overcoming mechanisms of cancer immune resistance. The keynote address will be given by Andrea Schietinger, PhD, Associate Member of the Immunology Program at Sloan Kettering Institute. Dr. Schietinger investigates immune regulation and checkpoint interactions, uncovering mechanisms to overcome T-cell dysfunction and enhance cancer immunotherapy efficacy. Other notable speakers include Padmanee Sharma, MD, PhD, Director of Scientific Programs at the James P. Allison Institute, and Professor of Genitourinary Medical Oncology and Immunology at MD Anderson Cancer Center. Dr. Sharma's pioneering work in neoadjuvant immunotherapy has been instrumental in defining the mechanisms of response and resistance to checkpoint blockade. Betty Kim, MD, PhD, Professor of Neurosurgery at MD Anderson Cancer Center, and co-chair for the James P. Allison Institute Internal Advisory Council. Dr. Kim explores immune and vascular mechanisms in brain tumors and develops targeted immunotherapies and nanoparticle delivery systems. Antony Rebus, MD, PhD, Professor of Medicine and Surgery at UCLA Johnson Comprehensive Cancer Center and former president of AACR. Dr. Rebus is a global leader in melanoma immunotherapy, bridging bench-to-bedside research in checkpoint blockade, adoptive T-cell therapy, and neoantigen targeting for solid tumors. Fred Ramsdell, PhD, founder of Sonoma Biotherapeutics and the 2025 Nobel Laureate in Physiology or Medicine, recognized for his pioneering work on immunoregulation. Together with Mary Brunko, Dr. Ramsdell identified FOXP3 as the molecular determinant of regulatory T-cell function, uncovering mechanisms fundamental to autoimmunity, cancer, and immune-based therapies. Please welcome Dr. Sangeeta Goswami.
Good afternoon, everyone, and congratulations for making it to the final session of the third JPAI Symposium. And what I would like to say, you might be exhausted by now, but I want to assure you the stage is still strong with a lot of good scientific talks that's coming up in this session. And talking about exhaustion, who better can talk about exhaustion and wake up all the exhausted T cells in this podium rather than our keynote speaker, Dr. Andrea Schietinger. It's a true honor to invite Dr. Schietinger on the stage, who has redefined the transcriptomic and epigenetic pathways of exhausted and functional T cells, and how do they crosstalk spatially in terms of anti-tumor immunity. Stage is yours, Andrea.
Thank you so much for the kind introductions. Thank you for inviting me. Pam and Jim, this is such an amazing symposium. So I'm so honored to be here in this lineup of speakers. So yes, I hope you're not exhausted. I'm talking about exhaustion, so let's just get going. What I was thinking is, because the audience is about not just immunology, but also cancer biology, I'm giving a little bit an overview, conceptual overview of what the Schietinger Lab thinks about T-cell dysfunction, exhaustion in tumors, what we need to understand in order to reprogram T cells successfully, especially for treatment of solid tumors. So let's get started. Okay. Title of my talk, T cell differentiation, what we can actually learn from T cells in the autoimmune context. This is the central question that I have been trying to understand since I started my graduate work at the University of Chicago. Why do CD8 T cells not work in eliminating cancer cells? And we have been very much trying to understand and look inside of a CD8 T cell, how they are transcriptionally and epigenetically programmed and so forth. And at the end of my talk, you will realize that we are not working really only on CD8 T cells anymore, not in cancer, in order to understand and address the answer to that question. So we use preclinical mouse models, and we claim we somehow recapitulate human disease, where we induce cancers in normal tissue, and we let them grow for weeks and months. And then we track T cells over the entire course of tumorigenesis. Because if you want to understand how T cells become dysfunctional or exhausted, you need to really track them from the earliest events throughout the end stage. And so we did this. We followed these T cells over from tumor initiation to end stage. And what we found was that the T cells enter pre-malignant lesions, and right when they see the cancer cell, they shut down their effector program. And this is in a context where you don't have this immune suppressive microenvironment and so forth. And then with time, this gives the cancer time to grow. T cells become even more dysfunctional based on the surface and upregulation of many inhibitory receptors and so forth. And when we ask the question, can you actually push these T cells back into a functional state? Yes, early you can, later you cannot. So we proposed this idea that a PD-1 positive dysfunctional T cell can be in two stages, epigenetically reprogrammable or fixed and imprinted. And we wanted to understand what are the transcription factors that are the ones that really tell a T cell, you're dysfunctional, but we can push you eventually back, or you are really dysfunctional and imprinted. And so this epigenetic regulation led to the identification of a transcription factor that I'm going to talk a little bit about, TCF. And in the beginning, the T cells express this good TCF transcription factor, and with time they lose it. And the transcription factor that is responsible for all this establishment of the bad epigenetic wiring is this transcription factor called TOX. We were super excited to find this master regulator. We claimed it's a master regulator. We need to target it, and then we basically prevent this pass into dysfunction. And this is basically, that was the study where we completely rethought the definition of T cell dysfunction exhaustion and what drives T cells in this dysfunctional state and why. So this is the story about TOX, which I'm going to just briefly summarize because it will be later important for the unpublished stuff I'm going to present. So we used T cells that were able to express normally TOX or TOX-deficient T cells here in red. And we put them into tumor-bearing mice. And what we saw, that the TOX-deficient T cells, so we knocked it out in these tumor-reactive T cells, were completely normal-looking. They were unable to upregulate any of these inhibitory receptors, and we were very excited, also transcriptional and epigenetically, they had absolutely no signs of T cell dysfunction. But then, when we took them out and we asked the question, are you actually a more functional T cell now? The answer was no. So despite that a T cell can look completely normal in the tumor microenvironment, these T cells were not a bit more functional. And so we went back a few weeks later, and another surprising thing we found was that these TOX-deficient T cells that were completely normal looking completely disappeared. And there is much more that we did functionally in many other groups also in the context of chronic infection. And I want to just summarize what we think this TOX-induced exhaustion phenotype is actually for and why it's established on the surface of a tumor-reactive T cell. So when you're a T cell and you go in a tumor and you get activated and you see antigen all over you, then that causes this chronic TCR stimulation, which drives this upregulation of TOX. And TOX is the master regulator, we think, that is responsible for the upregulation of all these inhibitory receptors, PD-1, CTLA-4, LAG-3, and so forth. And I was taught that these are bad molecules because we target them in immunotherapy, and that is true. But when you also look in the earliest publications that people have described the identification of PD-1, LAG-3, and CTLA-4, you actually will see in these original papers that a T cell that you activate in a dish in vitro upregulate within 24 to 48 hours super high levels of PD-1, LAG-3, and so forth. So they are not just inhibitory receptors, they're activation markers. And what are they? Why are they upregulated? Because they are negative regulators that tell the T cells you should not be getting overstimulated when you see this TCR stimulation. And this is a physiological negative feedback mechanism to protect the T cells from getting overstimulated, undergoing activation-induced cell death. And this is what allows T cells to persist in context of persistent antigen. And we thought we are smart, we are knocking out tox. And what we realized is that we are losing now this physiological negative feedback mechanism. Now the T cell has nothing on the surface to protect them from overstimulation. And this is the reason why in tumors and in other contexts, what other labs have shown, you lose these tox-deficient T cells. They undergo activation-induced cell death, and they don't persist. So we think that this tox-induced exhaustion phenotype on the surface that we profile with the upregulation of all these inhibitory receptors is actually absolutely required for T cells to persist in the tumor. And so downstream of the TCR, you have the module of the phenotype that is tox-driven, and people call it the exhaustion phenotype. But we propose there is a second module downstream of the TCR, which is responsible for loss of effector function, which has nothing to do with tox, and I'm going to show you data in autoimmunity and then the unpublished stuff that kind of support this idea. And we are looking into now what are actually then the factors that allow a T cell to secrete interferon gamma, TNF, granzyme, perforin, and so forth. Okay, so tox is important for persistent, but it doesn't regulate effector function. So now the question is, okay, so how do you then reprogram? Clearly knocking out tox is detrimental. We are losing the T cells. And we had some other papers, and people actually then came up to us and said, you know, very insightful, but always very sad ending your stories. You never ever give us hope or show, you know, you actually with your proposed mechanisms, you can eliminate a tumor, and that is true. Until then, I have never really cured a tumor in a mouse. So I took this to heart, and I thought, okay, so what do we have to do in order to reprogram T cells to effectively eliminate a large solid tumor? And so we thought a little bit outside of the box, and we argued, what does the T cell have to bring to the table? It has to maintain effector function in an environment where it gets chronically stimulated with antigen. And that is an autoimmune T cell. So an autoimmune T cell is a T cell, self-reactive, that goes in peripheral tissue, sees self-antigen, gets kicked on, and in this case, we have the opposite problem. It cannot shut down effector function and destroys an entire organ. So we argued, as a tumor immunologist trying to reprogram T cells effectively for immunotherapy, maybe we need to understand how autoimmune T cells are wired. Because if we understand what is the master transcription factor that keeps those autoimmune T cells going, that is the transcription factor that you want to bring into the tumor reactive T cell. So this was the kind of idea behind everything. And we started with the question, okay, where do actually autoimmune T cell responses get initiated? And how do they sustain tissue destruction? And we chose a model that is widely accepted in the field, a clinically relevant model of type 1 diabetes. Why type 1 diabetes? Because type 1 diabetes is this classical autoimmune disease where you have CD8 T cells going into the pancreas and continuously eliminating beta cell. And so Sophia, back then, she joined the lab and said, okay, what I need to do in this model, the so-called non-obese diabetic mouse model, I need to track T cell differentiation from the earliest stages when the disease begins to end stage when they really have wiped out every single beta cell. And so what was known in this model, and this was all done a few years ago with amazing collaborators who really from day one supported us and made sure we are going in the right direction, that beta cell-specific T cells get activated in tissue-associated or tissue-draining lymph nodes. And in this case, in type 1 diabetes, it's the pancreatic lymph node. So people have shown before that that's where the T cell for the first time sees antigen draining from the pancreas, gets activated. And so Sophia said, okay, then I'm going over weeks following the fate and the phenotype and the cell intrinsic programming of these T cells. I follow them. And so now I'm going to summarize the findings to lead then into the newer part. So what we found was here you see pancreatic lymph node, and in the pancreas we can detect these beta cell specific T cells. And we asked first, okay, how do they look? They express high levels of PD-1, CD39, and many other of the inhibitory receptors, the same way as T cells in the tumor context. So a reflection of antigen encounter, but not really affect their function, because when we took them out and we asked the questions, are these PD-1 T cells, positive T cells, autoimmune T cells functional? Yes, they are. So they make high levels of interferon gamma and TNF, and that causes destruction of normal tissue. We also looked at tox expression. It's very high. So phenotypically and based on tox, it looks exactly the same. So then we are like, that is weird. You have a T cell which looks the same, but continuously eliminates normal cells. This is exactly what you want in the tumor context. And so we looked for transcription factors, and one transcription factor stood out based on its unique expression and heterogeneity. We looked in the lymph node, and we saw actually that there were two populations, a TCF1 positive population and a TCF negative population. And in the pancreas, mostly those were TCF low. And so we did many molecular and functional studies. We isolated them, in fact, and we transferred them into secondary hosts. And what we found was that in the lymph node, the TCF high positive, PD-1 positive population transferred into secondary hosts were able to induce the disease, but not thousands, 500,000 of T cells isolated from the pancreas. And we did many molecular analyses and functional analysis, and we came basically to this conclusion. In autoimmune disease, you have in the tissue-associated lymph node what we call a stem-like T cell, an autoimmune stem T cell. There are only a few cells in the lymph node. They sit in niches, and we are trying to understand what are these niche factors that allow them to form and to sustain. And they self-renew constantly, but at the same time, they shoot out and generate these TCF low T cells every single day. They travel to the pancreas, and that's where the heavy lifting killing is happening. And you need absolutely the replenishment from these few stem cells to generate constantly these differentiated progenies in order to sustain tissue destruction. So now the question is, okay, what does then autoimmunity teach us, and what do we need to learn for the successful reprogramming of T cells in the cancer context? And so this is the picture, tumorigenesis. You start from normal tissue, the T cells become dysfunctional early on, that allows the tumor to grow. How do you end up on the right side with successful tumor destruction then? Autoimmunity, and also starting from normal tissue. And we think that the initiating headquarter where the fates are determined is during the priming and activation phase in the tissue-associated lymph nodes. In autoimmunity, we are really deeply now invested in understanding how do these autoimmune stem T cells form, why do they form, why do they not sustain potentially in the lymph node during tumorigenesis. And so just preliminary data suggests in the beginning you actually start with a somewhat like stem-like T cell, but over the course of tumorigenesis you lose them, and we are trying to understand why this is. Okay, but there's also the effector phase, where the stuff is happening, the destruction is happening in the tissue. And so we were interested in understanding now, okay, what can we learn then from autoimmunity, not just looking in the lymph node, but also where the action is happening in the tissue itself, where you destroy the cells. And you could argue and say, well, Andrea, you have a tumor, and yeah, a naive T cell comes, doesn't get activated maybe with inflammatory context like you would have in an infection or in autoimmunity. And then you have this persistent antigen. No wonder you are ending up with a PD-1 positive, tox positive, TCF negative T cell. But what never really made sense to me was also when we look at the context or the setting of adoptive T cell therapy, because there you don't need to go through the tumor draining lymph node activation and so forth. There you engineer or generate highly functional T cells. You adoptively transfer mostly CD8s into a patient with a solid tumor, and the efficacy of eliminating cancer cells is very poor. Even in this context where you generate the most functional cytotoxic effector T cells. So now putting a few things together from autoimmunity and potentially also from adoptive T cell therapy. And when you look in autoimmunity, for example, such as type 1 or multiple sclerosis, you actually realize that the allelic, the genetic association with disease, despite the fact that you have pathogenic CD8 T cell, it's not MHC1, it is MHC2. So MHC2 is the allele that is the highest association with disease. So clearly CD4s must be doing something. And in the mouse model that I'm not showing, we are wrapping that story up, we know that the CD4s are absolutely important for allowing these stem cells to form and to persist. So we put these two things together. In addition to adoptive T cell therapy, largely giving CD8s not working, we asked the question, okay, is it possible that the CD4 T cells are required for CD8s to actually execute cytotoxic effector functions? And this was a work from Gabi, who is now a postdoc, who is now back in Barcelona. So you can say, okay, CD4s, we know they're important for CD8s, and that is true. So beautiful work has been shown, and the person is actually sitting in the first row, Philip Greenberg, one of the earliest to show that you need CD4 T cells also for priming of CD8 T cells, and then for recruitment of effector CD8 T cells to peripheral T cells, and that CD4 T cells can kill directly in an MHC1 non-dependent manner. And CD4 T cells are required for the effector phase. That was not known. So we asked, is there a novel role for CD4 T cells? And so we used a very reductionist approach where we engineered tumor cells that express CD8s and CD4 epitopes on the surface in green and in blue. And so we let the tumors grow. We gave in vitro activated CD8 T cells. We adoptively transferred them, and nothing happened. So we argued, okay, this is maybe in some patients that are resistant to adoptive T cell therapy. When you then give in vitro activated CD4 T cells, every single tumor melts away. And we have now done this with autochthonous cancer models, and we find exactly the same. So now the question was, is this a numbers game? Do the CD4 T cells help just to get more CD8 T cells into the tumor? No, it's not. Before the tumor regresses or progresses, we have exactly the same number of CD8 T cells. But cell intrinsically, they're very different. The ones who have help from CD4s make high levels of interferon gamma TNF. The ones who don't see CD4s cannot. And so we then did an experiment what was really crucial to understand the mechanism. We took 2 million of these CD8 and CD4 epitope-expressing cancer cells, and we did one experiment where we mixed actually the two cancer cells together, but not where they express both, but where you either have CD8 or CD4 epitope. 1 million, 1 million. So you give exactly the same number of cancer cells. Then we did exactly the same transfer of CD8 and CD4. So everything is the same. And here is the outcome. We saw that the ones where you gave the cancer with both epitopes together was eliminated, but when you have the mixing, the tumor grew, like you wouldn't have even given T cells. And when we zoomed into the cancer, we could see that there are these mosaic patches where the CD8s expressing ones grow next to the CD4 expressing one. Numbers were exactly the same of CD8 and CD4. So clearly CD4s and CD8s, the numbers don't matter. But potentially what is important is the spatial organization. And so now over the next 5 minutes, I'm going to tell you the mechanism, what we think is absolutely required in order for CD8 T cells to kill a target in tissue. So we asked the question, what is it in the stroma? And so we deleted actually the dendritic cells in the cancer. And when we did this experiment, the model failed. So clearly, the CD8s and the CD4s, together with the dendritic cells, need to do something in order to cause tumor elimination. And we showed this not only for adoptive T cell therapy, but also for ICB, immune checkpoint blockade context. So we came up with this model and said, maybe the way how this works is that the cancer cell must express, or a target cell must express both antigens. And because they are physically linked, they always get presented on an antigen-presenting cell, a dendritic cell, the same way. And that forces now the CD4s and the CD8s to sit on the same cell. That allows the local reprogramming, and that allows then now the CD8 T cells that are reprogrammed to go back to the cancer and kill the cancer. When we mix the two systems together, or the two cancer cells, where you don't have tumor elimination, this can never happen, because they're never physically together on one and a single cell. Okay, so this was the idea. APC, CD8, CD4, 3-cell clusters, and we called them triads back then, are required for CD8 T cells to become cytolytic and eliminate cancer cells in tissues. So what was known about triads? Not much. We found one paper from 1987, which is in O'Malley, where they showed you must have triads, a 3-cell cluster, for allo transplant rejection. And so, but nothing was known in the cancer context. So we asked the question, is it possible that in the one context where you have tumor elimination, you form these increased numbers of triads? And this was indeed the case. So you can see that there are much more of these triads, these 3-cell clusters, in the tumor before it regresses versus in the other system where they progress. So we think that these triads are absolutely required for cancer killing through a CD8-mediated mechanism. And so do they really need to sit on the same APC? Yes, they do, because we did recently an experiment where we did bone marrow chimera, where we had chimeras where you have MHC1 knockout or MHC2 knockout. So in these mice, you have MHC1 and 2, but never on the same cell. And when you do these experiments, what you find is the model falls apart. So this really shows you it has to be the same cell. And in addition, what we now know is that these are long-lasting engagements. That's the requirement, because when we have initial tumor rejection, then we take the CD4s away with depleting antibody, the model doesn't work anymore. So coming to now to the human context, because in the end, this was mouse. So is there some idea about what happens in humans? And this was with an amazing collaboration between Matt and Hyung and Brian across the street, actually, where they had a patient cohort, mesothelioma patient, where they were treated with anti-PD-1, anti-CTLA-4, and they did resectional surgery pre and during onset of treatment. And they had patients which responded and non-responded. And they did this massive spatial analysis. And we went to them and we said, who is predicting that you are going to be a responder or non-responders? It wasn't CD8 T cell infiltration, the numbers, not CD4s, not diets. The only prognostic marker was actually the numbers of triads. We looked and zoomed into these triads, and you can see that when a CD8 T cell is together with a CD4 and an IPC, it makes much more interferon gamma granzyme. And what was also interesting, the CD4s in the triads were not FOXP3 positive. So clearly, this drives somehow the reprogramming of CD8 T cells. And I want to just highlight 2 papers which are supporting this idea on triads and have shown this. Miriam Murat and Alice Kamphorst in HCC patients who were treated with PD-1, and Nihar Cohen, who has shown there are these niches, or hubs he calls them, on CD4s and dendritic cells, and in close proximity, these TCF-positive CD8 T cells. So now we think there is a new role for CD4s in anti-tumor immunity, that you need to have them at the site where the target is in order for elimination, successful elimination. And so now the ongoing efforts are obviously to understand what are the signals. Can we identify what these signals are? Are these cytokines? Are these receptor ligand engagements? Can we engineer CD8 T cells or CD4 T cells to cooperate in cell therapy? Or can we engineer vaccines and so forth to enforce triads? And now, because I'm almost up with the time, there are two more slides where we then ask the question, what is the cell intrinsic program and the phenotype of these CD4 T cells? And in CD8s, we know the CD8s in the tumor are tox positive, and they don't do anything. But what about the CD4 T cells? And so this was work from Brianna, a graduate student who is now graduating. And so we looked actually, do CD4 T cells express tox? And yes, in vitro, when you activate them, Th1s make high levels of tox, and that correlates with high levels of interferon gamma and TNF. So we said, when we knock out tox, what would happen to these Th1-like polarized T cells? Well, they are not Th1-likes anymore. So here we knock out tox, and they cannot produce interferon gamma anymore. We did this also by CRISPR or genetic tools. We have exactly the same outcome. You must express tox in CD4s in order to make interferon gamma. TNF and other cytotoxic molecules are not affected. So now the question was, okay, is this then correlated with human responsiveness? Because it would be the opposite as tox in the role of CD8s in the tumor. So we used two papers, the bladder cancer paper from Lawrence Fromm, who is now at the Fred Hutch, where he treated patients with PD-1. He identified these CD4 T cells that are CXCL13 positive. They are the ones who are associated with clinical responses. We reanalyzed the data, and we find that those are actually expressing high levels of tox and make high levels of interferon gamma. We went back to Miriam's paper and analyzed them. She also identified the phenotype of these CD4 T cells in triads, and we find that they are high expressing tox and interferon gamma. So now, wrapping this up, we actually think that tox is required for CD4 T cells to drive interferon gamma and anti-tumor immunity. And now coming back to autoimmunity, this is exactly what you also see in human autoimmune context. That in this autoimmune disease, for example, the cytotoxic CD4 T cells that are the pathogenic ones are the ones that make the highest levels of toxin interferon gamma. So with that, I'm going to conclude. Basically, tox is responsible for the persistence of CD8s, but is always associated with dysfunction. And we think that in order to successfully reprogram CD8 T cells for anti-tumor immunity, you must have tox-positive CD4s. So we think that tox-positive CD4s are a prognostic marker that could predict therapeutic responses, and we are thinking about overexpressing tox for CAR T cell and so forth, adoptive T cell therapy. And so now this is where I'm going to end. Tumor, T cells, CD8s, autoimmunity. We are looking at two sites. The lymph node, where everything begins, with the creation and the sustained formation of stem T cells, but then also looking at the effector phase, where in the tumor context we think we must have these triads and these tox-positive CD4 T cells. And what is now really interesting to say, okay, you go to a type 1 diabetes patient. Do you see potentially these triads? So we are actually looking into what are the pathogenic epitopes. And what we now actually find is that the CD4 immunodominant pathogenic epitope, the sequence of insulin B, for example, is listed here, is always together with the CD8 epitope. So you see that in autoimmunity, you have the CD4 T cells, but embedded the epitope is the CD8 epitope. And you never, ever actually express CD8 and CD4 independently and not on one APC. So that is, I think, where we are heading now, really trying to understand the spatial coordination. I'm wrapping up. These are the people who all did the work, the lab early, medium, more recent. all the amazing collaborators, and I'm thanking you for your attention and obviously for having me and giving me a slot to speak. Thank you.
Thank you, Andrea, for the tour de force talk. This was amazing. We would have time for one question. Lingua.
Beautiful work, incredible. I have a quick question about the intratumor immune triad. What are the microenvironmental factors drive the spatial organization of those triads? Are all triads functionally involved in tumor elimination?
Yeah, this is a great question. I would even go one step back to your question and say, are you sure it's only DCs that are part of this triad game? Because some people in the audience could be B-cell people, which then come up to me and say, what about B-cells? And I say, we haven't tested it, and it could be totally true that in our system, the dendritic cells are part of it, and it would suggest also with the other literature that was published. But it would be interesting to ask, is it just that the APC is allowing the CD4s to go together with the CD8s, and it doesn't even matter? So is it just an APC that expresses MHC1 and 2? Or is there something cell intrinsic really important of that APC, which goes then to the microenvironment and how they form and where they are and how they create the spatial composition? These are all open questions that we are trying to address right now, yeah.
Thank you.
Thank you.
Thank you, Andrea. And now it's time to introduce the next speaker. Actually, I think it's unfair that they asked me to introduce Dr. Pam Sharma within 1 minute. It would be very difficult for me to do that, but I'll try. Dr. Pam Sharma, she has been a visionary immunotherapy leader who initiated the first neoadjuvant immunotherapy trial even before the first FDA approval. She started it in 2006, and that led the whole field of immunotherapy. And from her, I learned that we need to learn from every patient. And she insisted running clinical trials where we learn immune monitoring from every patient. And more than her scientific discoveries and pioneering effort, one thing I would also like to focus, that she has been a pioneer in building the scientific community that we are seeing in Allison Institute today. So with that, floor is yours, Pam.
Okay, thank you, Sangeeta. It is really sweet when you have somebody who worked in your lab for so many years become their own bright star and then come up to introduce you, so my honor. So today I'm just going to briefly give you a little bit that we're doing now in the lab. And a lot of the work you're going to see today, I just want to call out the spectacular postdoc, Shelley Herbrick, who did the clonal hematopoiesis work that I'm going to present. So I just want to say that up front. So the title of the talk is Investigating Mechanisms that Enable Responses with Immune Checkpoint Therapy. And we've been doing this work for a long time. These are my disclosures. Basically, you know, having been around since anti-CTLA-4 was called MDX-010, and that's what it was called. It was a very cool name, by the way, MDX-010. And we were able to then do those first clinical trials and see the responses. Oops, the slides are moving much faster than I am. Okay. And so anti-CTLA-4 clearly opened this field of immune checkpoint therapy. And then, of course, PD-1 and PD-L1 antibodies, and now LAG-3. The cartoon is basically to show you how many other pathways we still have to understand to really move the work forward. And then this okay. And then the next slide, if I can, there we go. And next slide is showing a number of FDA approvals since 2011 when anti-CTLA-4 ipilimumab was then approved. And so it's very important to understand that immunotherapy is not really about the drug being infused into the patient, because really the drug is a prodrug, right? It's really allowing for the immune system or the T cells to be the drug. And then that stays with you your entire life. And you're not targeting a specific antigen that it has to be, just bladder cancer or just renal cell carcinoma. It's that it can do this with all different tumors because the T cells are going to have responses against different antigens to different tumors in the patients. And that's what makes the field so powerful, is that the immune system can keep up with whatever antigen is being expressed. And what we're giving to the patients are the prodrug to really get the real drug, the immune system, to do the work and to stay with the patient long term. So this has really led to a lot of different questions that we've tried to address in the lab over the years, right? Why do some patients respond and others do not? What are the mechanisms of response and resistance? Are there other pathways that can be targeted to improve clinical outcomes? Can we increase the number of patients who respond? And can we identify targets to mitigate immune-related toxicities? I won't have time today to talk about immune-related toxicities, and all the other questions are really big questions, but I'm going to really walk you through a little bit of how we've been looking at it. So one of the things we always remember is that as an MD and a PhD, we straddle that interface between the lab and the clinic. And so in the laboratory, we're very used to doing hypothesis testing in models like mouse models, where it's inbred and the disease is homogeneous, and we can ask a very distinct question. If you knock in a gene or knock out a gene, you understand how that pathway works. However, patients are polymorphic, the disease is heterogeneous, and when we're running the clinical trials, really we're just getting correlative data from the patients, and that's hypothesis generating data. And so with over 2,000, maybe even up to 3,000 clinical trials ongoing now, it's very important for all of us to start to think of how to integrate the lab and the clinical research. And we do this through a reverse translation mechanism, where we're obtaining all of the samples from the patients and then studying that in the laboratory to understand mechanisms that we can then test in the appropriate immunocompetent mouse models, use that data to then go back into the lab. And so we're doing this in ways such as the neoadjuvant clinical trials, for example, where we know that phase 1 studies are safety dose escalation, phase 2 is efficacy, and phase 3 is comparison to standard of care. What we did was introduce this concept of pre-surgical or tissue-based clinical trials, or these neoadjuvant clinical trials, which we call phase 1A and phase 2A studies. And these trials are small trials, 10 or 20 patients, so they're not designed with the same statistical design that you would use for these other clinical trials. They're really designed to help us gain insights into clinical signals, obtain samples for biomarker analyses, and maybe drive some understanding of mechanistic insights. And we initiated these trials in 2004 with the first trial obtaining FDA approval, the first trial obtaining IRB approval prior to FDA approval of ipilimumab in 2006. So just to quickly walk you through this trial, because it was published a long time ago, but just to show you again, this is a 12-patient trial, and this was the first neoadjuvant immune checkpoint therapy clinical trial. It really established for us that one, immune checkpoint therapy can be given safely in the surgical perioperative setting, right? We now set the standard for many, many other neoadjuvant clinical trials that are being conducted. Because we had that clinical signal for safety, we can continue to do these kinds of studies. It also gave us a signal for efficacy because it was the first study in bladder cancer patients, and we saw that 3 patients had complete responses. So it led us to do larger studies where we could get immune checkpoint therapy approved for patients with bladder cancer. And then finally, of course, it gave us access to all of the samples at the time of surgery so that we can actually ask what's happening in the human tumor tissues, what are the human immune responses that are changing over time as a result of treatment. We also did another neoadjuvant trial in patients with bladder cancer, and this one was a combination clinical trial, just to show you again that it doesn't have to be monotherapy. As we're thinking of new novel combination strategies, these can also be brought to the neoadjuvant setting. And this was in anti-CTLA-4 plus anti-PD-L1 in, again, small numbers of patients, 24 patients who had localized bladder cancer, and they were not eligible for cisplatin chemotherapy due to other medical comorbidities. And since you're not eligible for neoadjuvant chemotherapy, you have a very high risk of recurrence, and a lot of these patients had large masses. There were about 12 patients with large masses. It was not even sure that we could get a good surgical resection. But these patients went on to therapy, and you can see, even in the patients who had large masses, the pathologic complete responses were 42% in that group of patients, making it very feasible that these patients would have very good long-term outcome. So what were we learning now from the samples that we were collecting from these clinical trials? And so just to build on this idea that it's the interactions between different cells in the tumor microenvironment that makes a difference for outcomes, what we saw was that these were tertiary lymphoid structures. You can see the structure in the middle image here. And these tertiary lymphoid structures, we previously thought were only accumulated in lymph nodes. Right? It's in lymph nodes where you see T and B cells and dendritic cells, and all of these cells come together to form these structures. What we were finding was that these lymph node-like structures are now occurring in the tumor tissues themselves, and that's why they're called the tertiary lymphoid structures. They're not, they represent what we see in lymph nodes, but now this is happening within the tumor microenvironment. And we found that these tertiary lymphoid structures were actually much higher in the responder patients in the red box compared to the non-responder patients. And what were the components of these tertiary lymphoid structures? Well, we saw that there were these CD4 T cells, just as you heard from Andrea's talk, that were playing an important role. And it was these ICOS positive CD4 T cells that were increasing in the responder patients, you can see on the right, as compared to the non-responder patients, which did not have an increase in these. And now we're beginning to see how the ICOS ligand pathway is actually driving some of these interactions to allow for tertiary lymphoid structures and structures that allow for CD4 and CD8 T cells to communicate together. So in this codex analysis, and I want to give a shout out to Sonali Jindal and the immunotherapy platform because she's really done a spectacular job of getting codex working with 60 different antibodies. Here you can see now that these CD8 T cells, these ICOS positive CD4 T cells, and these BADF3 positive dendritic cells form these cell-cell interaction in neighborhoods that are associating now prior to or before you're starting to see then the formation of the tertiary lymphoid structures. And so now we have longitudinal samples that we're working with Linghua Wang to try and understand longitudinally how can we track the development of these structures. One of the things that we were thinking about as we were doing these sort of neoadjuvant and perioperative clinical trials, can we use the knowledge from the neoadjuvant clinical trials to change our approach to stage 4 solid tumors? So in the setting of metastatic or stage 4 disease, no one wants to do surgery because the patient has multiple lesions throughout the body. But is it feasible to perform debulking surgery of a single neoplastic lesion and give immune checkpoint therapy for patients with metastatic disease? And the thinking there being, again, as you remove a single lesion, you may have then antigen responses that can occur that immune checkpoint therapy would then amplify and allow for better outcomes in those patients. And I should preface that by saying that in the setting of chemotherapy or targeted therapies, tyrosine kinase inhibitors, when they tried to do this, when they tried to say we could use chemotherapy and remove a single lesion and give chemotherapy, it did not work. Right? So this idea of removing a single lesion and giving a therapy did not work previously. But again, I want to really remind you that immunotherapy is very different. It is not so much about the actual therapy we're giving. It's about the fact that the drug is the immune system. And can we change the immune system with immune checkpoint therapy in the setting of a debulking surgery? And so we wanted to pilot this idea. We did this prospective pilot clinical trial where we were able to have patients with metastatic clear cell renal cell carcinoma. And these patients received immune checkpoint therapy either with nivolumab, nivolumab plus bevacizumab, or nivolumab plus ipilimumab, as you see here. And then they went on to remove a single lesion. And in these patients, it could be the kidney. In 8 patients, there were actually other metastatic lesions that were removed. But because this trial was not designed for statistical comparison between the group who went to surgery and the group who didn't, we don't want to make statistical claims, but I want to point out to you that the patients who had immune checkpoint therapy plus the surgery to remove a single lesion, even though they had lots of other metastatic disease, had a median overall survival that's not reached and a 2-year overall survival of 86%. And so this was very reassuring to us to see that in the setting of a single metastatic lesion being removed, it is possible to improve outcomes for patients with immune checkpoint therapy in this setting. And hopefully now we can do a randomized clinical trial to really test this idea completely. What we found in that clinical trial, because again, we collected all of the samples, was that although interferon gamma was being touted at the time as the biomarker that predicts for outcomes with immune checkpoint therapy, we had patients who had very high levels of interferon gamma, as you can see in the red circle. And although they had very high levels of interferon gamma, these patients were still progressing, regardless of the immune checkpoint therapy. And so we wanted to understand what were the cellular interactions that define the responses, and is it really because of interferon gamma, and how can we then measure cell-cell interactions to determine other biomarkers of response? And again, using the interactions that you're seeing here, we were able to identify that the interactions, again, are consisting of these T cells and myeloid cells and B cells now, again, in the responder patients. Whereas in the non-responder patients, we identified clusters that were T cells and myeloid cells, but did not have these B cells. And I want to highlight Andrea's point that dendritic cells may also be the antigen-presenting cell here. It doesn't have to be B cells. But in this data set, it was B cells. And so we have to keep thinking about how we can drive these cell-cell interactions to have better outcomes. So then what are the mechanisms and pathways that can improve cell-cell interactions between T cells, B cells, and myeloid cells to drive tumor rejection? And can these pathways be used to select patients for immune checkpoint therapy, or can these pathways be targeted to improve responses with immune checkpoint therapy? And so now I'm just going to introduce this topic of clonal hematopoiesis, and can clonal hematopoiesis impact myeloid cell responses? So just to level set with everyone in the room, clonal hematopoiesis is an age-related phenomenon characterized by overrepresentation of mature blood cells arising from a single clone. And most of this is driven by somatic mutations in either DNMT3A, TET2, or ASXL1. And you can see now that when you go through the clonal hematopoiesis diagram there, that it's a myeloid bias where you're going to have these clonal hematopoiesis cells existing. So it's not really T cells, it's really the myeloid cells that are being affected. And it's really detectable in over 10% of healthy individuals 65 years or older. So for most of the time, clonal hematopoiesis may not have any impact, but there are times when it will lead to other diseases, such as AML, for example. So there have been many studies that have published that patients with clonal hematopoiesis are 10 times more likely to develop myeloid malignancies. There's also clonal hematopoiesis that significantly increases the risk of non-hematologic disorders, and there have been many publications on coronary heart disease, ischemic stroke, even severe COVID-19 infections. And then these mutated immune cells have been detected in solid tumors, and clonal hematopoiesis is also significantly associated with inferior survival in non-hematologic cancers. I want to highlight, too, that Charlie Swanton's group just published this beautiful New England Journal of Medicine paper recently this year, showing that, again, tumor-infiltrating clonal hematopoiesis was associated with worse outcomes in solid tumors. Now, these are not patients who have received any treatment. These are just patients where he was looking at the number of these infiltrating cells that in solid tumors. And what they showed was that there was this association with TET2 clonal hematopoiesis, and that there was a large percentage of TET2 mutant clonal hematopoiesis cells that were associated with these tumor-infiltrating cells. So we know now from these studies that TET2 mutant clonal hematopoiesis cells effectively infiltrate solid tumors and increase the risk of death among patients. But does TET2 clonal hematopoiesis drive differences in response to immune checkpoint therapy? Because again, TET2 clonal hematopoiesis will predominantly affect the myeloid cells. And we know that myeloid cells are important for responses to immune checkpoint therapy. So Shelley Herbrick in the lab decided to look into this question. And she developed this TET2 plus mutant heterozygous model to mimic the human phenotype, because most of the people, again, are carrying just the heterozygous TET2 mutation. They're not carrying homozygous mutation. And so she used the TET2, you see the mice are marked with CD45.2 for the wild type TET2, that she's then going to have the CD45.2 TET2 plus minus that she can track after she does these bone marrow transfer experiments. And what she found was that you can now look at these CD45.2 cells, and you can see that you're having a larger increase in them in the clonal hematopoiesis model, as you would expect, and better outcome when you give immune checkpoint therapy in two different tumor models here, pancreatic cancer and the B16F10 model. You can see that as you give these TET2 cells with immune checkpoint therapy, with reconstituted mice with the TET2 cells and immune checkpoint therapy, that's when you can see the improved outcomes as compared to any of the controls, whether it's the wild type or the wild type cells with immune checkpoint therapy. So this was the first indication that the TET2 phenotype does have an impact on immune checkpoint therapy. So why was this happening? How was TET2 acting to improve responses to immune checkpoint therapy? And what we were able to show here is that TET2 actually polarize macrophages so that they have more antigen-presenting phenotype. They're able to better present antigens as a result of the TET2 hematopoiesis, TET2 clonal hematopoiesis. And so you can see now, if you look for the scores, sorry, I don't have a pointer to look at all of the genes, but if you just come down here to the antigen presentation score, if you look at the wild type with immune checkpoint therapy and the TET2 heterozygous mutant with immune checkpoint therapy, you can now see the difference in the antigen presentation score that was calculated based on the on macrophages that we looked at. I will point out that these were looking directly at macrophages, but it is possible that dendritic cells, which we didn't look at in this study, could also fall into this category. And there's another study ongoing in the lab right now to look at dendritic cells. So these TET2 macrophages also promote effector T cell expansion, and you can see now that there's this increase in the T cells, CD8 T cell count as a result of these TET2 macrophages. What she did then was to then ask the question whether or not the TET2 mutant macrophages are sufficient to improve the immune checkpoint therapy responses. And here she could then take macrophages from the B16F10 mice or macrophages from the TET2 mutant mice, and you can then ask whether or not these cells are able to, when transferred into a mouse that has tumor, are able to then lead to the rejection. And it's only when you have the TET2 mutant macrophages that now you can see that you have rejection of these tumors. If she then gives an antibody against interferon gamma receptor 1, you can see now that you lose that response. And so it's clearly an interferon gamma driven response as a result of antigen presentation by these macrophages. We then worked with Caris Life Sciences, and so I know that some of them are in the audience, and I want to give a shout out to them because this was a really wonderful collaborative project where we can then ask in their patients where they've collected data from over 35,000 non-small cell lung cancer patients and 25,000 colorectal cancer patients, whether or not we see a difference from frontline therapy with TET2 mutations versus immune checkpoint therapy. And you can see frontline therapy, the mutation doesn't matter. It doesn't matter if you have a TET2 mutation for non-small cell lung cancer or colorectal cancer. But in the setting of immune checkpoint therapy, it does matter if you have a TET2 mutation. And here you can see that there's an increased overall survival in those patients who have the TET2 mutation, highlighting the importance of this TET2 mutation now to be a biomarker, similar to how you would think of microsatellite instability status, to now help drive selection of patients for immune checkpoint therapy. When they looked at biopsies of tumors from individuals with the TET2 mutant clonal hematopoiesis here, you can see that these tumors have increased interferon signatures, again highlighting this connection between TET2 mutant clonal hematopoiesis and an interferon signature, and therefore better outcomes with immune checkpoint therapy. These tumors were also found to have increased infiltration of M1-like macrophages, B cells, and CD8 T cells. So I think, again, we're starting to see that all of the data sets indicate that it's about the cell-cell interactions and how antigen-presenting cells can help to drive the CD4 and CD8 T cell responses. So I'm just going to conclude by saying that immune checkpoint therapy has certainly joined the ranks of surgery, radiation, and chemotherapy as a pillar of cancer treatment. Combination strategies are the future, and we really have to think about which combinations and which subset of patients will be treated. Both immunologic biomarkers, as you've heard a lot about interferon gamma and other immunologic biomarkers, as well as genomic biomarkers, such as TET2 and other genomic biomarkers, play very important roles in dictating outcomes to immune checkpoint therapy. I think that this TET2 clonal hematopoiesis will definitely play a role in dictating specific immune responses. We don't have any data on DNMT3A or ASXL1 yet, but I think it's important to look. And these will be novel biomarkers for selection of patients for treatment. And then I hope I've convinced you also that the neoadjuvant or pre-surgical setting and these tissue-based clinical trials provide a feasible platform for obtaining approval of therapy in earlier disease setting and to study biologic effects in patients, which provide insights into mechanisms that can be exploited for improving outcomes in patients. So I have many, many people to thank. Their names were on the slides. We went through them. But I do want to give a special shout out to all of the patients who participate in our clinical trials so that we can have access to the samples to study. So thank you, and I'm happy to take questions.
Amazing talk, Pam, as usual. So we have time for 2 questions. I can see one there.
Thank you so much for your presentation. I was just curious about the grade 4 tumor treatment. You say that surgery and the immune checkpoint both, and that works better. Is there any factors that chime in when you decide which region or which lesion has to have the surgery? Is it the primary tumors or other metastatic tumors?
So predominantly it was the primary tumor because this was metastatic renal cell carcinoma, so they still had the kidney intact. But there were 8 patients in that study who had previously had the one kidney removed, so they only had 1 left. We weren't going to do, but they had a metastatic lesion in the lung removed, for example, and they still had good outcome. I want to just correct you. We can't say it's better because I didn't do a randomized clinical trial. But I think the data is hypothesis generating to indicate that it would be, and we should do a randomized clinical trial.
Thank you so much.
Thank you.
Any more questions? It seems you are very clear, Pam.
Thank you.
Thank you.
Thank you. Can I take this?
Okay. Now it's my absolute pleasure to introduce the next speaker, who is a rare combination of a neurosurgeon par excellence and a pioneer biomedical engineer. And she is our very own Dr. Betty Kim, professor of neurosurgery at MD Anderson Cancer Center. Betty runs multidisciplinary platforms, immune engineering platforms, and she's tackling difficult diseases, taking biomedical approaches in different delivery systems. So Betty is going to talk about how she's weaving biomedical engineering, myeloid biology in treating cancer.
Good afternoon. Thank you so much for staying. And it's always difficult to follow Dr. Sharma. She's such an amazing speaker. It's an honor to be here today, and I really want to thank Dr. Allison and Dr. Sharma and the organizing committee for this honor of presenting some of our work we have. I guess I'd have to get the presentation slide here. So far we've learned a lot about T cells, which are a little bit more famous. They're more sexy in a way. But I'd like to sort of shift gears a little bit and talk about the myeloid compartment, the macrophages, and how we can actually modulate and target these cells so that we can actually get better either immune checkpoint or immune therapy efficacy and or even nanomaterial efficacy for nanomedicine design. And so why are we interested in macrophages? Well, they're the first defenders, really. When the host is infected by the foreign invasion, whether it be cancer or infection, it's the myeloid component, they're innate cells that come in and try and defend the host. They're also highly abundant in normal tissue, but also in tumor tissue, such as glioblastoma and pancreatic cancers. They perform many functions, but in tumor, they often lose the ability to perform their sort of innate functions of cellular defense. And so I think that there's lots of opportunities here where we can target the macrophages and put them back to their intended state, because they're like chameleons. They sort of change their phenotype depending on their environment. But also, can we actually do the opposite in certain organs, such as the liver? When we're injected with chemotherapy, immunotherapies, or some of these small molecules, a lot of these compounds are sequestered as a first bypass system in the liver. And so can we actually alter this medicine sink that macrophages in the liver, such as the Kupffer cells, sort of work hard at clearing so that your body is not intoxicated, I guess. So there are two stories, one in which we enhance the function of macrophages through a bacterial mimetic approach. And another, we actually want to decrease the macrophage function in such a way that more drugs can actually bypass the liver and get to the tumor and to their intended target site. So this is a busy slide. I just wanted to highlight just the few sort of points here. So if you're a cancer cell and you want to sort of sidestep this phagocytosis cascade where the host is trying to just get rid of you, there are some markers that are overexpressed in a lot of solid cancers, including CD47. These are overexpressed. They're known to be what we call don't eat me signal. When a phagocyte or a macrophage sees CD47 expression, they actually don't gobble them up and try to destroy it. And so there have been sort of approaches where we develop antibodies that recognize the CD47, as you can see in point number 1, where you can block this don't eat me signaling and allow more phagocytosis to occur where the cancer cells can be degraded. Unfortunately, I think there's a real opportunity that's lost here, because the second phase, the major phase of phagocytosis, is that they're sort of wrapped inside this phagolysosome, as Dr. Bertozzi spoke about this morning. And that is that the phagolysosome's intent really is to become very acidotic, chop up this tumor fragments, and destroy it and degrade it. And through a very random and very inefficient process, two major sort of phenomenons happen, if you will, where the tumor-associated peptides that are degraded either get loaded onto the MHC complex and shuttled for sort of presentation to the T cells and get them activated and recognized, or it can actually enhance the cytosolic sort of innate immune sensing pathways, such as the cGAS-STING pathway or the toll-like receptor pathway, because essentially if the tumor contents that are supposed to be within the phagolysosome are somehow able to leave that compartment and get into the cytosol, well, the cell knows that you're not supposed to have these DNA fragments or these abnormal sort of components of a tumor cell in there, and they start sort of shuttling this pro-inflammatory cascade in which cytokines are released and T cells are activated, and hopefully we can actually get T cells to recognize that cancer cell for eradication. And so this sort of pathway that I've sort of explained in detail is very important in the next sort of story that we're going to talk about. The first story was developed by one of our really creative and just brilliant trainees that we have here at MD Anderson, Ben Schrank, who's now just recruited as a physician scientist in the Department of Radiation Oncology, as well as a postdoctoral fellow, Yifan Wang, and a third-year graduate student, Annette Wu, whom you all met today, where they sort of looked at engineering approaches. The big bottleneck, I think, is not just targeting, but how do we escape the phagolysosome? And this is a problem not just for nanomedicines, but just drugs in general, where they just get sequestered with the cells. And so we wondered whether we can utilize what we know that happens in nature. We know that there's a bacteria, particularly intracellular bacteria, called Listeria monocytogenes. These bacteria are very smart. When they actually get phagocytosed by the host cells, they actually secrete this toxin called Listeriolysin O, or LLO as we're going to call them. And what happens is that the Listeriolysin O, under a certain pH, which is going to be acidotic in a phagolysosome, it starts oligomerizing and it sort of creates these pores within the phagolysosomal wall. And what happens is that the wall then becomes very leaky, and then the bacteria then is able to escape out of the phagolysosome. So using this concept, we thought, can we use this phagolysosomal escape mechanism and use that to enhance cytosolic cytosolic enhancement of the cGAS-STING pathway or toll-like receptor pathway, and or allow more of this antigen presentation to occur in a more efficient manner. So as I mentioned before here, the CD47 antibody, sort of kind of good at allowing more phagocytosis to occur of the cancer cell when they meet the antigen-presenting cells or the macrophages. But as I mentioned, many of the tumor fragments kind of get sequestered within the phagolysosome and can't actually get out. And so here we have this concept where using click chemistry, as we learned about this morning from Dr. Bertozzi, we took a monoclonal antibody, CD47, not as a way to kill the cancer, but just as a targeting agent that allowed a little bit more phagocytosis to occur. But we also use click chemistry and a cleavable linker. So a linker that actually detaches the LLO under a certain pH, an acidotic pH of about 6. And this is important because LLO on its own can be toxic, but when it's tethered to the antibody, it's not toxic. So you can imagine that once the cancer cell, which is coated with this CD47 LLO compound, gets sequestered into the phagolysosome, while the pH is around 5.8, 5.96, and the LLO cleaves off and punches holes within the phagolysosomal wall, and hopefully we were thinking that the tumor contents can actually leave and access the cytosol. And so this is a story. I'm just going to show you a couple of the figures that we presented in the paper. First, we wanted to just show that the CD47 LLO product, the first in class, I think, because it's not designed to kill the cancer cell, as I mentioned, but just to heighten the function of the macrophages. We co-cultured these with the bone marrow macrophages, as well as EO771, which are just breast cancer cell lines, and looked at the rate of phagocytosis. And you can see in this image here that there's a lot more of these green tumor cells that are entering and being eaten up by the macrophages. And it's quantified here, as you can see in the red bar, that the amount of phagocytosis that occur with the CD47 is much greater than just CD47 alone or some of the other controls. Well, when we take these cells and look at them under the TEM, or transmission electronic microscopy, we see that these sort of round blobs are phagolysosomes under very high sort of resolution, if you will. And what we did was, in order to look at the trafficking of what's happening from the surface into the phagolysosomal pathway, we also incubated this with gold nanoparticles, something that I worked on as a PhD student in biomedical engineering way back when. And you see that with CD47, they're able to actually get into the phagolysosome, but they actually just get stuck. They don't actually leave the phagolysosomal compartment. As compared to the CD47 LLO, you can see some of these gold nanoparticles that are now in the cytosol. And we also see the loss of the lyso tracker red because the pH difference between the lysosomal component and the cytosol is lost with the LLO. What's really interesting is that we then looked at, okay, now we know that they're in the cytosol. What are they doing? Are they actually improving their cross-presentation? And you can see in this in vitro assay that, yes, CD47 does increase the cross-presentation of peptides. But we also saw that this resulted ultimately in T-cell proliferation. And we looked at this, more details we can talk about later, but another pathway that I wanted to sort of talk about is the innate immune sensing pathway. As I mentioned, that as DNA leaves the phagolysosome and enters the cytosol, it activates the cGAS-STING pathway. And so we saw in the tumor-associated macrophages here that there's increased elevation of phosphorylated STING, but we also saw that there is a functional change as well, where we see increased interferon beta, interferon alpha, and as well as tumor necrosis factor expression as well through the LLO, CD47 LLO treatment compared to the other controls. And what does this mean in an in vivo tumor setting? Well, we took a variety of breast cancer models, syngeneic models, and we grew tumors in them, and we intratumorally injected the CD47 LLO compound. And we saw that not only did we see increased CD4 infiltration into the tumor cells, but also the CD8 T cells. And of course, we were excited to see this result as well, where we see reduction in the tumor volume of that injected tumor, but also improvement in the survival, as you can see in the red bars here. I think this is a study that was really exciting to us. And this is to show that although we were administering this drug or this compound locally, it actually had systemic or abscopal-like effects. And that is, we created this bilateral memory fat pad tumor model, where we grew tumors on both sides of this particular animal. And on the one side, we injected the CD47 LLO. And that is sort of represented in the red, just to be clear. And you can see that when we looked at the tumor volume over time, that as expected, that tumor on the left side, or the red, decreased over time. But we also saw the untreated tumor on the opposite side shrinking as well, suggesting that there's this sort of systemic effect of what we are sort of giving through local delivery. I think what's really interesting here is that given that there are sort of distant tumor control using local therapy, we took one of the most aggressive forms of breast cancer metastatic model. It's a 4T1 model. You can see a lot of these animals just essentially die from just being overburdened with so much metastasis, a metastatic model, so their body just riddled with cancer. And so what we see here is that because we also saw high rises of interferon gamma production, we added immune checkpoint blockade in this story. And you can see that at least 70 to 80% of these animals that should really be dead by 40 days or so continue to live long term. And what's really incredible is that the metastatic burden of these tumors shrink. And so you just inject this in one tumor, and all the other tumors surrounding and distant beyond actually shrink as well. Well, we took those long-term survivors, the 60 to 70% of the animals that are living long-term, we took the T cells from the spleen and co-incubated with tumor cells to see if they actually recognized these tumor cells. And I think this is one of the reasons why that the body now has this memory formation that it can actually now recognize the tumor. So if a tumor were to grow later on, your body will recognize it. If you already have widely metastatic high burden of tumor, your body will recognize that. And so I just wanted to show sort of this figure demonstrating that your body now has this very robust immune memory, not just to one epitope or one sort of peptide, but now there's an array of T cells that will recognize whatever tumor that may recur over time. And so Annette recently, with Dr. Kung's laboratory, has sort of developed this pancreatic model in our team. It's an orthotopic syngeneic sort of model. It's very difficult to establish it. But we're seeing similar results time and time again for different types of cancers, whether it be for melanoma, for breast cancer, for pancreatic cancer. Most likely, this is a model, or a pancreatic system will be most likely the first sort of human trial that we're going to try and dive into. And this is a very basic slide just to show the toxicity. Unlike the CD47 monoclonal antibody that are given as infusions, multiple doses in humans for liquid tumors, we're just giving this locally, injected either intratumorally or through the peritoneum. And so we did not see significant toxicity in the bone marrow or in the kidney or the liver system. And so I just wanted to sort of share with that we were able to use what is already occurring in nature and sort of hijacked these skill sets that they have developed, and that is to escape the phagolysosome in order to avoid destruction and allow that sort of host, or in our case, our macrophages, to work and function better. And so I think this is the first ADC in the field where the goal is not to kill the cancer cell, where the antibody targets the cancer cell and then unloads the payload, which is usually a cancer drug or some sort of a molecule that's supposed to burst the cancer. This is the type of a drug where we're not trying to kill the cancer, but we're trying to heighten the immune cells that are around it and trying to boost your immune system to go and attack it for long term. So this is great. I've got like 10 minutes, but I just wanted to go quickly on a paper that we just submitted. It's under revision. We're really excited about it. And that is phagocytosis is great for us if you're trying to eradicate cancer. But it's not so great if you're a drug developer and you want more of that drug to go to the rest of the body and not be sequestered within the reticuloendothelial system, such as the liver, the spleen, sometimes the bone marrow, and the lung. And so if you want more of the biodistribution of the drug to the rest of the body, particularly the target, such as tumors, you actually don't want as much phagocytosis, particularly in the liver, where a lot of macrophages reside. So as you know, the resident macrophages, such as Kupffer cells, are very, very efficient at clearing up foreign bodies, whether it be nanoparticles, chemotherapeutic agents, small molecules, what have you. And so the Kupffer cells macrophage function is very important. And I think that there's been lots of interest in this area, and also the microbiome with Dr. Wargo, I think she's in the audience somewhere, where it can actually impair sometimes the immunotherapy as well. And so we wondered, are we able to modulate the hepatic clearance of drugs? And what are its regulators? Because we're not really sure about that right now, and it's unclear. And is there a link between the gut microbiome and hepatic clearance? And that is a story that we came about through, and we can talk about it after the talk, the link between the two and how that came about. But I want to just highlight these three wonderful postdoctoral fellows in our laboratory, Meng-Yu Chang, Yifan Wang, and Jung Hoon, who are just brilliant. But also the Prime TR, the platform that we have at MD Anderson, led by Dr. Jennifer Wargo, so Nadim, Ajami, Lawrence Diggs, and Zoe Neal. So without their help, we would not have been able to accomplish this, which tells us that MD Anderson, it doesn't work in silos. You know, you have basic scientists on the one hand. Yes, the buildings are separated somewhat, but you've got clinicians, and you've got all these multidisciplinary efforts going on at the same time. And of course, we have access to a host of tissues, biological tissues, that it's a really an important thing in science. We can learn a lot from it. So what we did here was we took, I'm just going to simplify it to clean and dirty animals. So we have mice that are kept in very clean, germ-free facilities. And then we have sort of the run-of-the-mill animals that are just placed in specific germ-free sort of places where it's just, you know, your regular animal colony. And we took their liver macrophages, the Kupffer cells, and we looked at, are there any differences, first of all, in the way that they phagocytose or eat up nanomedicines? And so we initially did these phagocytosis assays utilizing different nanoparticles, including polystyrene that's listed here, liposomes, and lipid nanoparticles as well. When we saw the difference in the phagocytosis, where the animals that are in the clean room are not able to phagocytose them as much, because I guess they don't really need to do that because they're in a clean facility. But if you're a dirty animal, you actually want to be clean and want to make sure that your body is in a homeostatic state. Well, we then took the dirty animals, took their poop, and performed fecal transplant and administered sort of this dirty sort of FMT to the clean animals versus the clean animals to clean animals. And what we found was that the animals that really were not able to phagocytose very much, the amount of phagocytosis from dirty to clean animals were increased significantly. So you can see G, as in the clean animals, receiving dirty sort of poop, if you will. And the amount of phagocytosis is almost sort of similar to if you were just, you know, a dirty animal to start off with. So this sort of told us that you can actually change the way that liver is able to alter its macrophage function by changing the microbiota. We then wondered that since the microbiome seems to play an important role, can we actually alter the gut microbiome and see whether this also induces phagocytosis changes in these animals? And so we administered these animals with a whole host. So we took these dirty animals and these are just normal gut flora, gave them different types of antibiotics that we typically target the GI tract. And we saw for one reason or another, metronidazole, which typically are given to patients who have infections for anaerobic bacteria, these animals had the least amount of phagocytosis capability. And so I think that's probably because, as I will show you in the next slide, is a particular sort of collection of bacteria that are sort of eradicated by this particular antibiotics compared to all the other ones. When we look at the microbiome composition plot utilizing 16S ribosomal RNA sequencing, you can see in the top panel, this is just the normal sort of gut flora. There's a lot of coloring there suggestive of all the different bacteria that their healthy gut would have. And you can see in the metronidazole, there are certain sort of, particularly about 4 or 5 big classes of bacteria that are lost. And these are the anaerobic bacteria that are lost, including the Lactinospirae, I'm probably not even pronouncing that right, and as well as the Lactinosporidiums. And so we wondered, since metronidazole is able to reduce the amount of phagocytosis, we wanted to know, does that actually result in any metabolic changes? And we looked at bile acid sort of metabolism, and that's because liver produces bile acids. And the bile salts will then sort of shuttle to the small intestines, the duodenum and ileum. And what happens with the primary bile acids is that they get converted into these secondary bile acids called deoxycholic acids. And so that's sort of an indirect measure of this microbiome sort of altering your gut through this sort of portal circulation. And so when we look at the amount of this cholic acid formation, and here we have the germ-free animals, germ-free animals that were receiving metronidazole as we expected, very low phagocytosis. But if they actually received water, it's actually pretty good. And so, and the same patterns we see where the amount of bile acids are reduced in animals that receive metronidazole, as we would expect, with decreased phagocytosis, decreased activity of the liver, clearance, and then there's less of this metabolism that's happening downstream. Well, we took the liver macrophages and performed single-cell RNA sequencing. And what we see here is a collection, and I can't point and I can't jump high enough, but you see this collection of orange sort of dots, and they represent the C2 phenotype of these macrophage subsets. And these, the orange C2 sort of group actually is enlarged, or there's a lot more of them following metronidazole treatment. And when we looked at the genetic sequencing of gene sequencing of what these population of C2 macrophages do, well, these are populations of macrophages that have lost the capacity to phagocytose, antigen cross-present, and even induce like NF-kappa B signaling, sort of the innate immune signaling. So now you have this sort of shift, if you will, of the phenotype of macrophages, where there are more of these macrophages that are not able to perform macrophage innate functions like phagocytosis. When we look at the fluorescence imaging of these animals to look at where the drugs are going, so we injected these animals with either Abraxane or Doxil. These are nanomedicine formulated chemotherapeutics. We see that in the metronidazole group, because the liver is not able to take as much of them in, that more of this drug at the same concentration is actually entering and targeted into the tumor site. You can see that in the left panel. And that actually was exciting because this is a way in which you can use the same amount of drug but get higher efficacy of the tumor sort of control. And so this is a busy slide. I just wanted you to focus on these two graphs, which is just showing tumor control versus survival. And when you basically take an animal that you treat them with metronidazole, then give them a chemotherapeutic agent, whether it be nanomedicine or just a standard chemotherapeutic agent, that you actually see an improvement in the survival just by giving them metronidazole, which, and I think that's all coming through the changes in your gut microbiome. Okay, so I've got maybe one or two more slides. This is just to show that you can actually recreate the metronidazole process by altering your gut microbiome with FMT. So summary then. Gut microbiome is shown to improve immune checkpoint recently, but its impact on chemotherapy is just unknown. We don't know yet. And this gut-liver axis, I think, is a sort of a new sort of area that I think we can really use as an opportunity to have better efficacy in drugs that we may already have that we're targeting already. So these are all of the members and collaborators that we've worked throughout the last 5 years that I've been at MD Anderson. and of course the funding support and the great team that we have here. We just have such brilliant trainees at MD Anderson. Thank you.